Menopause just means cessation, so stopping of producing eggs and periods.
As soon as there's something that might be impacting men, it's like, right, all the studies, all the money, Viagra. And you know, women classically kind of plough on.
It's a life stage, so we should teach it like puberty, this is what's going to happen, and then menopause is when your periods stop, and have that whole teaching. It doesn't do the company any favours, because they're losing that talent, where if they had those support processes in place, they would have kept that.
Or making notes.
No, when I tell you, making the notes. Hello and welcome back to the Social Matters podcast. We are three social workers talking about social matters. But today we are joined by the fabulous Dr. Elise Dallas.
Woo!
Welcome to the pod.
Dr. Dallas.
Dr. Dallas.
Great ring to it.
Such a good ring to it.
It also sounds like you were a character in an American soap opera, not called Dallas, but it's just Dr. Dallas.
Exactly, that's why I kept my name and didn't have my married name.
Love that. So very welcome. We're so pleased to have you. Fran and Elise, you know each other, don't you? Do you want to say a little bit about how you're connected?
So we lived together in a house share in Brixton in South London about 15 years ago.
I know, you've just reminded me how long ago it was, and we haven't actually seen each other since.
I know, terrible.
Yeah, we were randomly put in there, but it worked well, didn't it?
Sounds like Big Brother.
Yeah, it was a bit like that.
We were randomly put in there.
Yeah, at the end of the Friday nights, but
The debauch
it was
days.
good.
We won't go too much into it because that was like pre-husband and children for you, and just
Absolutely.
pre what for me? Oh God! I'm still doing that thing. Anyway, we digress. But yes, thank you for coming on. That is a connection.
Oh, and yeah, it was just really lovely to kind of hear your chats about you being a social worker back then and you being a doctor. Were you doctor back then?
Yes,
Yes.
I was, so I was doing my GP training.
Yeah.
So that's how long I've been a doctor for.
All right. Well, we are really pleased to have you. We've been wanting to have a chat about the menopause for a really long time. And so we are so excited to get this conversation kicked off. But yeah, so our first question is, could you tell us a little bit about yourself, about you, what you do, and also how you came to have a special interest or focus in the menopause?
Yes, absolutely. So as I've just alluded to, I graduated in 2004 as a doctor, and then you do your GP training, which is when I was living with Fran. And so I've been a doctor now for 20 years and a GP for 17 years. And I think it goes along with just being a woman. I've always been attracted to the phases of womanhood, I guess, that I've been going through. So when I had my children, it was, antenatal, postnatal, and now being 48, I'm very much interested in menopause, and this is my stage of life. Yes, it happens to be one of the big things that everyone's talking about now, which is great, but it's really, it almost goes into longevity about how you're going to really live the next 30 years of your life. And lack of awareness, it's really just important to make people aware of menopause and what our next stage is going to be like. But no, I've always had an interest. I've worked in Papua New Guinea, setting up women's health clinics, in Nepal with breast cancer clinics. So I've always had an interest in women's health, and now it just happens to be menopause.
Fascinating. Thank you.
For some people, I suppose, menopause and perimenopause might be a new or unfamiliar topic. And even myself, peri was not in my vocabulary. Or
I don't think it was in anyone's vocabulary until 5 years ago.
Yeah.
Oh, wow.
Yeah. I sort of thought I had an understanding of what menopause meant, and actually my understanding has grown a lot in the last 5 years. So I suppose for those who it might be a new or unfamiliar topic, would it be okay just to say what kind of perimenopause and menopause is?
And I think it's really important, and often it all gets, dumped into the one big menopause.
Yeah.
So, which is fine, but I
Yeah.
think if we clarify things, then it might be a bit clearer. So menopause just means cessation, so stopping of producing eggs and periods. And so we wouldn't diagnose you being menopause until you've not had a period for a year. So on average, that's about age 51. But it's slightly different for different cultures. So Afro-Caribbean, it's about 49. South Asian, it's actually about 46. But you can't say you've you're menopausal until you've not had a period for a year. So it's quite a finite day, and it's often a diagnosis made in hindsight. However, perimenopause is when the hormones start to fluctuate, and that is the time leading up to that last period. So it's the transition period. It's when you're still having periods, they might start becoming irregular, you might start having symptoms, and that can be about 6, 8, sometimes even 10 years before this. So on average, a normal menopause, so your last period, can be between age 45 and 55. So if you think about the years before that, so 10 years before that, you could start having perimenopausal symptoms 35, late 30s, early 40s. And so that's where the awareness really comes in, and you're thinking, oh my goodness, could this be my hormones?
Yeah.
And so once you've become menopausal, it's then called postmenopause.
Yeah.
Okay, so you're either perimenopausal or postmenopausal, and menopause kind of encompasses, well, that one day when you've not had a period for 12 months. Premenopause is before perimenopause. Okay, so that's when you're having regular periods. So you'll be premenopausal, having your regular periods each month, and then as your ovaries start to fail, they start shooting out fluctuations of estrogen. And that's when your periods may become a little further apart, a little closer together. And then you'll start to experience the symptoms, potentially. And there's sort of different symptoms to go along with that.
Yeah.
So, just listen to you speak as the only man here. I never had any sort of education around this, and I knew the terms, but then as you start to speak, I realised I didn't know what they meant, and because the terms get used here and there, and like you said, they all get bunched
Exactly.
together,
So
but
we sort of call it the menopause transition. So it's really when your ovaries are starting to fail, and that sort of encompasses all the definite. I know.
Malfunction.
Yeah, malfunction and stop, because we're born with a finite number of eggs.
Yeah.
And so, and people get confused between perimenopause and premenopause. So it's just essentially, you because everyone's like, but my hormones go up and down anyway, and that's true. But in premenopause, they're going nicely regular cycles. They're going up and down, and each month you're producing a period, if obviously you're not getting pregnant. And then as the ovaries start to fail, the fluctuations of estrogen might make your periods a little bit closer together. Usually we can tell some people don't get any period changes, but most people get a few days. So if it changes, let's say you've got an average cycle of 28 days. If you start becoming a little bit late or a little bit early, you start, lots of people track their periods now. If you start getting 30 days or 26 days, that's a week out each month, and that's early perimenopause. Yeah, so you're starting to enter perimenopause, and that's when you might start having some symptoms. When you start skipping a whole period, for example, so it's more than 60 days that you haven't had a period for, then you're later in that perimenopause. So your final period should come in the next 1 to 3 years. It gives us an idea, and that's when the symptoms are. But you can actually have another thing called early menopause or premature menopause. And so menopause is remember, you've not had any periods, it's your final period. So if you have your final period between the ages of 40 and 45, that's early menopause, and that about 5% of the population have that. And if it's actually sadly before age 40, then you have your final menstrual period, it's about 1%, but we're starting to learn there's probably a little bit more people having that.
Yeah.
And you can have that for lots of reasons. You can have that because you've had surgery, and you might be put into surgical menopause where you've had your ovaries removed because of endometriosis. It's about 7,000 women a year that go into early, or premature menopause because of those reasons. Or chemotherapy, you're having chemotherapy for breast cancer, and they may give life again, but they may not because of the radiotherapy and chemotherapy and genetics.
You said earlier that it's only really now we're kind of having the conversations, and it's only really been in the last 5 years or whatever. What happened in the last 5 years? What happened 5 years ago, do you reckon, to make it happen?
Well, it's always been there, and no one's talked about it. But if you look at women's health research, women's health research, only like 2% of, the national research goes on women's health. Women just haven't really been in the spotlight, as you know, like women's health in general. And so menopause also, 100 years ago, we didn't live as long as we do now. The average, we used to die after our menopause. So average menopause is 51. We used to die, after 60, 70. And now the average lifespan is 83 for a woman. So that's 30 years more without those hormones. And so we want to live that in health span and not just lifespan. We want to be healthy, bones, hearts, brains. And so it's really important that we prepare for that now. But then people, social media's come about, the internet, how we access knowledge, research. Like I said, there's not been too much research, but that's why I think probably from the 70s that we've really started to notice and pay attention to menopause. But there were big studies back in sort of about 23 years ago, so 2002, where lots of people were put on HRT. That was the average. Everyone was put on HRT. I remember my mother was on it. I was at medical school at this time. And then a big study came out then saying it was linked to breast cancer.
Yeah, I remember.
It's all sort of, I remember my mother literally throwing it in the bin.
Yeah.
And I remember, obviously I was being trained at that time. Anyone that walked in with, I'm part of that cohort that was trained and quite nervous about treating anyone with menopause because I was terrified of HRT, as were the patients. So it's only now we've got body identical, we've got different ways of treating it, and it's about awareness and saying, look, we don't have, and re-looking at those studies and realising it wasn't a causation effect, and that estrogen is useful for lots of things, but we'll come on to that later. But that's why it's sort of all changed.
Thanks, Elise.
You mentioned earlier about symptoms, physical symptoms that women experience in perimenopause and menopause. Could you just explain a bit about what are the physical symptoms that people would experience in perimenopause?
So we sort of usually split it into sort of physical symptoms and psychological symptoms, let's say. So physical symptoms, the typical one, you see, woman fanning herself, hot flushes. So they're called vasomotor. So the temperature controls goes out of whack. So you could either be waking up drenched in the night, sweats, people have to change the whole sheets, or suddenly this massive hot flush comes over you, and at any point of the day. But they're often late, so they're not often typically what someone would come in and see me with. There is palpitations. People suddenly get palpitations out of the blue, itching skin, tinnitus. We've got lots of vaginal symptoms. So there's something called genitourinary symptoms of menopause, which is a big mouthful now, but at least it encompasses the pelvic and urethra and your bladder, whereas it used to be called senile vagina and vaginal atrophy, which literally means withering away. So... And these are symptoms that most women will get because we've got estrogen receptors there, and the older we get, and if we don't treat it, then the skin gets very thin, so people can come in with painful sex, lots of urine infections, dryness, soreness, feelings of thrush, but it's not. So they're sort of more physical symptoms. Also, there's the weight. I mean, it doesn't sound good, does it? The metabolism changes, so we start gaining weight more around our tummies. Got that middle age bulge, we call it, and that's sort of metabolically active and puts us at risk of higher diseases like diabetes. And then you get dry skin, dry hair. They're the physical symptoms usually. And then psychological are usually insomnia. You might have difficulty getting sleep, might have difficulty staying asleep, waking up early. Something called brain fog, which just means you just can't switch on. You walk into a room, you think, God, why have I come in here? You can't remember where you've left your keys. Where are my glasses? They're on your head. You can't remember names. Names is a big one where you're in a presentation, you're trying to present something, and you've forgotten your boss's name, or the person you're presenting to, or why you're even doing anything. Rage is a big one. So suddenly having absolutely no tolerance for the people around you, and absolutely, a lot of frustration. Anxiety that comes out of nowhere. So lots of people have been anxious their entire lives, but this is different. It's like suddenly like being really nervous to drive at night, for example, or being really nervous to meet up with people that you've been, meeting up with for years, or something that makes you suddenly very anxious all of a sudden, and you just can't control it. So they're the main symptoms, and then low libido. Just not interested anymore, haven't even thought of it. Plus, obviously, if you've got like dry vagina, it's sore, you're not going to be really in the mood. So these all go together. And to be honest, most people don't come to me going, gosh, I'm sweating so much, please can we get rid of them? That's a sort of by the by. Most people can often deal with that. It's the brain fog, the insomnia, the emotional aspect that people often going, I can't actually cope, I can't even do my job right. And so that's usually that's the perimenopause, where it starts creeping in. Periods might start changing by a day or two. They might become heavier because the progesterone is the first hormone to drop, and then these sort of psychological symptoms start coming in a bit. You might have a bit of temperature control, but that's a little bit later often.
So interesting that you said, firstly, my days, like what a bag of symptoms.
I know. When we were all like,
okay.
I know, and that's why it's really useful to have something like a symptom checker.
Right.
And there's loads available.
Yeah, that's helpful. So where were they available? What?
So it's gone, the green climacteric scale is one of them, but if you literally download, there's lots of apps, but download something, menopause symptom checker, and see if it comes in, a monthly cycle, see if it starts happening a little bit before your period, see if it's just coming randomly. And because it's so insidious, I often say, look, compare what you were like this time 6 months ago, this time a year ago. And they're like, oh my God, yeah, actually, no, definitely worse. Because it creeps in. And obviously we're living in we're a sandwich generation. We've got older parents, potentially younger children. We're in the peak of our career. We've got a lot of, I know we talk about equality, but a lot of it always falls onto the woman. You've got your household, you've got your career to run, and sometimes it's just too much. But yet you used to cope a year ago, or you might have coped a couple of years ago. So it's about finding what's changed for you.
Yeah, really helpful. Yeah. Thank you. You've mentioned a little bit about no, don't be sorry. Super helpful. You mentioned a little bit about work and the impact of the menopause, if a woman's going through menopause while at work. Like, can you speak a bit about? Are there things, or should there be things in place in the workplace? Like what is your experience of supporting workplaces to kind of help them think about, employees that are going through the menopause or perimenopause?
So absolutely, this is a massive thing, because obviously we spend almost half our lives in our careers, don't we? And no one wants to lose their job or leave it. And unfortunately, 10% of women actually leave work because of menopause symptoms. And, so that's got two aspects. One, they're possibly, 80% of women don't go to the GP to do anything about their menopause symptoms. Lots of people don't know that they are menopause symptoms causing this, because like I said, they're thinking, oh God, I've got, just anxiety, or, what's happening? I've just got overwhelm. And so they might not recognise that something can be done potentially about these symptoms. But then there's also, if no one is aware of what the menopause is at work, you've got embarrassment, you've got shame, you don't know what to do about it. And so a lot of people will call in sick, not say why they're calling in sick. They're not talking to their line managers, potentially because there isn't any training. There isn't an open culture, an open talk about it. It's not normalised. And then that sick leave goes into longer and longer periods. They're not performing. They're not, not being able to present at work or whatever it is that they're doing. They've got really achy body, another one, which is a really big one, because estrogen's all in our joints. They might be suffering that they can't feel that they can do their job any longer, and then call out and that, call off sick or leave their job. And that doesn't do anyone any favours. It doesn't do the woman who's midlife, who, let's remember, we've got another 30 years to live, any favours. It doesn't do the family any favours. There's no income coming in. It doesn't do the company any favours, because they're losing that talent, where if they had those support processes in place, they would have kept that. And so I'm very much, I speak at women's, for, workplaces, employers, to recognize symptoms. And I'm not asking someone to be a doctor. I'm not asking someone to know exactly what to do. But I think it's about normalizing it, having that open culture. Yes, you can have a menopause policy, but for me, it's more about just having gender equality at work. It's not about asking for any special favors. If someone is suffering, I would want them to feel that they could approach their line manager. Their line manager might not know what to do, but potentially they've had training, so then they can be aware that menopause might present in different ways to different peoples, and then they can have that open conversation. Lots of workplaces have set up things like menopause cafes where people will go along and speak about their symptoms and just normalize it. It's about education, having the employers trained, and having conversations where they might want to, make provisions for that person, not necessarily just sign them off sick. So they might want to be a bit more flexible. Insomnia is a massive one. So if you've been up all night having night sweats, start a little bit later. If you're not going to meet that deadline because, you've dropped the ball for some other reason or some symptoms, then maybe be a bit more flexible with that. Sitting by the window, having provision for maybe going to see a doctor, and maybe recognising in that woman that, she can go and seek help and speak to a doctor about how she can help her symptoms.
Thank you. Talking about symptoms, I wanted to ask when you after you gave us that bag of symptoms earlier, what are the things that help? What are the things that you can do? Yes, HRT, hormone replacement treatment, therapy. But then, I was just wondering, are you on that for a period and then it's only while you're on that, then what happens afterwards, and how is HRT the only kind of way to kind of help? Just help. What are some of the
So that's a
ways to help?
huge question. And that's, so I like to think of it as I think most doctors do now, as kind of your menopause toolbox. So yes, we usually put it into lifestyle, which is applicable for everyone and anyone. HRT, which is replacement of those hormones, which I can go into, and then non-hormonal therapies, and then potentially alternative therapies. So if we looked at lifestyle is for everyone. And so that's where, for those that haven't even hit perimenopause, you could start preparing yourself. But so if we looked at exercise, we know that when you hit menopause, estrogen helps with bones. And so bones start to thin. And bones actually start to thin from the age of 30. And with something called sarcopenia, also our muscle mass. And so for longevity, to live long as a healthy person, we really need to increase our bone strength and our muscle strength.
We're all making notes.
When I tell you, making the notes.
So getting into strength. So I grew up in sort of the 80s where it was like, be skinny, eat less, bowl of Special K, get skinny for your holiday. We've got to kind of get rid of that, which I think is starting, and getting strong, really, and really building that muscle, really building that bone strength. Obviously, cardiovascular is good also because that's good for your heart health. But combining those two exercises, but also balance health, and also, there's no point in trying to, lose weight because lots of people are worried about gaining weight if you're stressed, because cortisol is just going to keep all that fat on you. So it's about doing, calming exercise like yoga or Pilates or something calming, reducing your stress. So that's another pillar, stress. So trying to reduce that stress. Obviously we all thrive on a little bit of stress, but if we're all up here, it's not going to do our heart, our brain any help, or our hormones any good. And there's nutrition as well, obviously. Prioritizing things like protein. I'm not saying a protein only at all. I'm definitely into, protein, complex carbohydrates, and good fats. Making sure we're getting our vitamin D, omega-3. A lot of people always ask me about supplements, but I really just think nutrition is best, and you should only be supplementing if you're falling short of not being able to get that in your diet. So vegans, B12, because you can't get that from vegetables. But otherwise, you should be getting, the B vitamins, and basically eating a good, 30, we're looking at gut health as well, because that's how we metabolize hormones, make hormones as well. Our gut health is really important for our immune system. So 30 plants a week, trying to get that fermented food in. And so it's really just starting to make those little habits that are going to serve us well into our midlife and beyond. Sleep as well is a massive one. Prioritising sleep, it's much better to sort of get those 6-7 hours sleep than running on stress or getting up earlier. And again, when you have that sleep, so trying to get to bed before midnight, having a real good routine. If you have difficulty sleeping, then, new little habits that I've put in is like I look at daylight as soon as I wake up, because that resets that circadian rhythm, so you're then tired later on, because we're all here in a studio, we've all got I was going to say fake, but artificial lights and on our phones constantly stimulating us, waking our brains up, and so getting that good sleep, but that's lifestyle. Then there's do you want me to dip into
therapy, please do.
So hormonal therapy, essentially, as I said, when you go into perimenopause, your hormones start doing this. And so the main one is sort of estrogen. It's going up and down, and that it's generally not the low level, because post-menopause you're not producing estrogen. So you're doing this in the perimenopause, and then you sort of flatline it after post-menopause. And it's those fluctuations that are actually causing the symptoms. So, and especially hot flushes, that's really caused by the fluctuations in estrogen. Lots of other symptoms can be caused by, not very good lifestyle, for example, or overwhelm. So it's a real clear indicator to me when someone's definitely having those hot flushes, that it's fluctuating estrogen at bay. So what we would want to do is potentially, for those that are open to it, and most people under 60, the benefits outweigh the risk. If we look at hormone therapy, it benefits two aspects. One, it is the first line for symptoms control. It's very safe. We have newer hormone therapy now, body identical, and so body identical estrogen, and so we give that, and we often give it through the skin, so that avoids any clots at all. And so it's very safe. It's very different to the estrogen that you might have experienced in a combined pill, for example. But if you have a uterus, so if you haven't had a hysterectomy and you have a womb, imagine estrogen is like a fertilizer. So it's building up that womb lining. So we don't want to do that, because it's okay for a little period of time, but if we just keep building up that womb, then we risk having something called endometrial cancer, because there's a risk of cancer forming if you're building it up and up and up and up with no shedding. So progesterone we have to have as well. And that is like our lawnmower, as it were, and it keeps it nice and thin. And depending on where you are, whether you're perimenopause or where we put it in cyclically, so you mimic your period, you put it on for 2 weeks on, 2 weeks off, or post-menopause, where you just have it continuously keeping it thin. Because once you've stopped your periods, you don't really want to start bleeding again. And so, but the body identical, so the natural progesterone also has a nice calming effect. So people quite like that, especially if you've been having sleep problems or anxiety. People respond quite well to the natural progesterone. Then there's another one called testosterone that it's really big at the moment. But that's not necessary. Our estrogen does a lot. And so we will often see, let's get you estrogenized enough. Let's see how you are on the estrogen after 3 months. Then if they're still having low libido, we might consider adding in something called testosterone. Then there is the vaginal estrogens, which is extremely safe. Even for, when you're having, after you've had breast cancer treatment, it's very safe, and it really treats the vaginal symptoms that you might be experiencing, and that comes in pessaries and creams. So, but that wouldn't affect you systemically. But the other effect of hormone therapy, not just to treat symptoms, is you've got the added benefits of it helps osteoporosis, or it helps thinning bones, it helps preventing you get thinning bones, obviously with all the lifestyle as well. But that's one really good effect of estrogen. Plus, it already helps your cardiovascular, so your heart health. It reduces your chances of having a heart attack or stroke by 50%. So, but obviously with all the lifestyle, there's no point sort of sitting and having a Big Mac and taking estrogen, because you've got to do a bit of everything.
Yeah.
And so, and there are only a few people that can't take it, and that would be if you've got an active cancer at the time and certain other conditions. But in general, if you are suffering from symptoms, go along with a doctor that knows about HRT, has experience of prescribing it, and have a discussion about whether it's a right option for you. You know, I've seen people where the surgeries have said, oh, we don't prescribe HRT until you've stopped your periods or until you're after 50. And that just doesn't make any sense at all, because that's not when you need it. You may need it when you're in that perimenopause. And I'll often give people a trial of it, see how they feel. If none of the symptoms are improving, then it's probably not hormonally driven. Okay, so it's all in about taking that history when that first person, you know, when initially that person walks in. There are other non-hormonal things like antidepressants. They are also shown to help with mood stability, can help with sleep, and they can, as a side effect, help with some hot flushes as well. So that might be an option for some who have maybe had breast cancer, which is hormonally driven, for example, and they can't take HRT, or some people who just don't want to and would like to try non-hormonal. There are some other complementary therapies like CBT, so cognitive behavioural therapy. It's not going to get rid of your hot flushes, but what it helps you do, as with any CBT, it helps you perceive it differently and learn how to cope with that, or potentially the anxiety or whatever, or the insomnia or whatever symptom that you're experiencing. It's all really, really, really individualised, because you've got to look at your family history, your medical risk, you know, whether you're perimenopausal and you're still needing contraception, for example, whether you're postmenopausal, what's the risk for you to develop osteoporosis, what's the risk for you developing heart disease, potential cancers. So it's really, really individualised, and it's about what you want as well, what symptoms are bothering you, and whether you want to do something.
So helpful to hear the kind of options, and it kind of offers some hope. Could somebody experience...
I hope it offers some hope. There is definite hope.
I'm joking. Could someone experience perimenopause and the menopause with no symptoms, asking for a friend?
Absolutely. And so some people go through menopause, and this no it's well, exactly. And so you may not experience any symptoms. So luckily about 10 to 20% of women may not experience anything. Okay. But it's only when I'm talking and someone go, oh, actually, no, I do have that achy body. I feel like an old lady when I get up in the morning. I thought that was just age. Or, oh, God, I thought I was just getting a bit panicky. I just, you know, for no reason. I thought it was just this extra workload, or, you know, my relationship issues. It's about knowing, has something got worse since you've hit kind of potentially around your early 40s for a typical person, and are there any period changes, which obviously some things mask the period changes, like contraceptive pills, or if you've got the Mirena coil. And Mirena coil is also a good progesterone if you needed that as part of your HRT treatment as well. But there's about 10 to 20% of women that may sail through menopause and are clearly saying to everyone, what is the fuss? We just got through it. We didn't feel anything. But often on questioning, I think you'll find that they did suffer some symptoms, but it wasn't enough to bother them, and that's fine. And it's not saying you have to go on HRT at all, as long as you're doing those. I think the pendulum's almost swung in, you know, the other direction. You know, we all scared to prescribe HRT. Now everyone's getting a bit of FOMO if they don't get HRT. But if you've got a great lifestyle and all the other parameters, your cardiovascular health, bone health is on the right trajectory, then and you're not having any symptoms, then there's no need to take HRT. It's not, you have to take it at all.
Is it available to everybody? It's not a sort of postcode lottery?
No, it's available to everyone.
HRT.
And just on that, there's if you do get it, there's something as of last April called HRT exemption certificate. So if you decide to go on HRT, it's about £19.60, and you for the whole year's supply. So you apply for that, and you get your little green NHS slip, and you tick that box at the back. So
super helpful. How much training, out of curiosity, did you get at medical school on kind of the menopause? Because a podcast we were listening to with Halle Berry, the actor on it, I think they were saying about like, it's, I don't know, a very
page.
small amount. And the reason I say that is because I got called by my GP for a health check. I'm going to be 44 in a month. So I'm probably, I'm in that stage.
Good. You got called by your GP.
I was like, wow, proactive.
Yeah, it starts from age 40.
But I was like assertive outreach. So I went there and they asked me 0 questions.
Oh.
And I thought that would be a question of
absolutely.
and
so this is
so they just were like,
this is
okay.
what we're trying to get into.
Yeah.
So for your that's a really good question, because for your 40-year-old health check, it's generally just screening you for cardiovascular.
Yeah.
And so they may do a diabetes check and a cholesterol check.
That was,
Yeah. And you do your blood pressure and your weight.
That was what I had yesterday.
Exactly. But what we're pushing for is, why not grab these people while you have them there and at least just make someone aware of what menopausal symptoms might be, so they know where to go. And I don't think we're too far off it. And I think good GPs and people that know about menopause and have potentially done some extra training, they would be asking that. I mean, it's certainly what I do. But yes, that starts from the age of 40. And then if everything's clear, you go at 45. And yes, it should be asked.
We've heard you've got a kind of interest or speak around the advancements or use of technology as a kind of innovation within perimenopause and menopause. Could you say a bit about kind of technology in this space and how it's being used?
Yes. So, like I said, there's very limited, or historically, and we're trying to change it going forward, been done on women's health research. So, obviously, how do you fix a problem if you don't know what the problem is? Okay, so that's the first thing. It'd be useful to get more money into research so we know what problems there are to be fixed. And so that's why I was quite interested about the wearables, about how Aura, do you know the Aura ring? Yeah. So it's a ring that tracks sleep and heart rate and temperature and heart rate variability. And Clue, do you know the Clue? It's like a menstrual app. So it tracks when your period is and your symptoms. And so these are often bit of the millennial generation. I guess they love tracking and a bit better at it. Where are your Aura rings of tracking? But they've teamed up together. So what they're doing is they're hoping that these women will submit their data to see if there's, when people are starting to enter perimenopause. Because if you're tracking when your periods start and you're tracking it along with your sleep and you're tracking it along with your heart rate and your heart rate variability and your temperature, we're going to start giving that sort of empowerment back to the patient or the woman, going, oh, these are starting to come out of sync. I'm starting to enter perimenopause. And it just gives us a little bit, it's those metrics that some people like. Obviously, it's not all about that, but it's, and obviously this isn't the best way to collect data because, but it's raw data, it's real data. And so hopefully we'll get lots of women sharing their data, because lots of women have been in the past. I think if we understand how data is shared, people are a bit nervous to share their data. So hopefully they'll have already gained the trust of their already, their followers or their subscribers, and we'll get that data. So that's quite an exciting project. There's also sort of physical ways of actually treating the symptoms. So thermography is, do you know what thermography is? No. Do you want to guess what it is?
Sounds like something to do with
listening sounds.
photography. I don't know. I'm thinking about lightography, photography. I don't know.
It feels like a quiz question.
So it's material that helps with hot flushes. So it's this breathable material that takes away the hot flush, so you're wearing it. So so it's that's new technology in that way, quite physical. Then there's things like sort of
takes away a hot flush. How does that work?
It's within the technology, but it somehow absorbs it and takes it away and helps with that temperature control.
I sweat at the best of times, so I feel I need that now.
So look it up. And then there's sort of a bracelet that will also pick up when you're having a hot flush and send a cool chill. And so remember, they're not going to help anything else but that particular hot flush, but that could be really useful for those that can't take HRT or anything else, although they don't want to, or that's their only symptom. Then there's, you're talking about Halle Berry. She's got Respin, which is a whole sort of care journey where she's using the wellness, the CBT, and helping someone end to end on that journey of menopause, as have lots of other menopause care journeys. You know, the service, as it were. It's just not all in an app, but that, you know, you've got virtual care to try and access as many women as possible. There's sort of Coral and Carrots. These are menopause care journeys, which have basically got virtual services and other lifestyle additions in terms of management. And then there's things like ovarian rejuvenation. So yes, we're talking about giving you body identical, but there's also working to make the ovaries kind of last a little bit longer. That's more looked at from a fertility perspective, but if you're doing that, then that means the menopause might last a little bit, you know, come a little bit later. So there's lots of innovations coming up, and hopefully we will see more and more, because I think millennials especially are going to be a little bit more consumer led. They're going to be wanting to get care, you know, through their wearables, virtually, and drive that care themselves, and they'll be a little bit more proactive, I think.
So I'm just here taking it all in, because I'm just realising, we mentioned the Halle Berry podcast, is that is the first bit of education that I've had around perimenopause and menopause, and then just listening to you speak, I'm just like, it's just going to another level, and it's just making me think about like where on the life cycle journey, because like in school we learn about sex education, like maybe from, I don't know, as women, where did you get your education around periods? As a man, I have had nothing about that. So besides turning up to GP at 40 to tell you about, where on that life cycle do we get
that's
that
exactly
education?
so in the future, that's where education should start. So I've got 11-year-old and a 7-year-old and boys, and my 11-year-old is currently doing sex education, and the poor thing knows everything about periods because he's had me in the house, and so they know everything. But it's true. It's like, do you learn anything about this? It's very scientific. We've got the big diagram of the ovaries, and I got very excited, teaching him, and he's like, "Oh God, please just stop it." And I said, "Well, this is what I do, and then the ovaries run out, and but that's where it should start, and because it's a bit like puberty. It's a life stage, so we should teach it like puberty. This is what's going to happen, and then menopause is when your periods stop, and have that whole teaching, so it's not all shrouded in stigma. It should just be culturally normal to talk about it, and I think we're far away from that. But I think things like this, social media, podcasts, talking about it, normalizing it, because that's another interesting, the thing that attracted me to menopause is because it happens to everyone. So lots of things in women's health may only happen to a certain cohort of women, like endometriosis, painful periods, having a baby. But menopause at some point will happen to every single woman. So everyone will go through it, whether they have symptoms or not, but more usually they will. And so we have to prepare our young girls for it.
It just so wasn't talked about, was it? It is one of those things. It's so
and when you go back to education, when I was at medical school, I got very little. But remember, I was in that cohort when it was 2002, when my mother chucked the HRT in the bin. And so from that point on, I had this fear of HRT. But then it was based on, that study was based on synthetic, oral, higher doses of estrogen. Very different women, average age was 63, whereas now we're looking at starting it in 40s and 50s. And they had diabetes, they had lots of other comorbidities or obesity, they smoked. So it was very different, and we've reanalyzed that. So I'm much more confident. There's lots and lots of free education there for doctors to get menopause trained. There's lots of specific qualifications, but it's getting better, but I think we just need to keep talking about it. I was about to say, every man loves a woman, don't they? Whether it be their mother, their sister, their partner, their daughter. As a society, sorry, but women do hold up usually the family, and so we've got to keep supporting them. Otherwise,
for sure.
they won't be able to support the rest.
Yeah, and that kind of touch, and I think you've answered this question to an extent, but it touches Halle Berry's getting shout outs on this podcast. She's not even
We'll have
paying
to
us
at
for it,
her
yeah.
and then
Have to
get
at her. But when I listened to that podcast, one of the things that stood out to me was like she talked about the impact of not being able to talk about perimenopause, or like you were saying around vaginal saunas and not and low libido, not being able to talk about that with partners is a real kind of can contribute to impacting on relationships, but also on friendships and on society. So like, what are your hopes around the impact of education around this?
I think if you don't know what you don't know. So if you are if you are more aware of what the symptoms are, so that whether that be through education as a child or teenager, certainly it normalized. This is where potentially technology can come in. I've seen teenage apps talking about puberty, but incorporating menopausal conversations in that. But it's the same with any women's health. Lots of people just don't speak out. They don't speak about women's, heavy periods. Oh, well, my mum had it, so I'm just going to suffer through and have heavy, painful periods. It's about really empowering that woman to know when something doesn't sound right, or you're not happy with it, or it's impacting on your life in some way. Advocating for yourself, being able to get that education and going and making that woman feel empowered so she can go to her doctor and have that discussion. And whether that be with a partner who might recognize it, if we're all educated and it's all normalized, then hopefully we won't be sitting at home with that stigma. And that's why actually, these famous people or influencers, they have that platform, and in some ways they're using it wisely to educate and normalize it. Because didn't she get misdiagnosed as having genital herpes? And it was but then my friend last week got she's got this terrible itching, awful, and went to see her doctor, who is a menopausal woman, so you'd think that they might be better advice, but she was just told to put yogurt on it.
Yogurt?
Yeah, that's a traditional old-fashioned way for thrush, but it wasn't thrush, because it was cyclical. Every month she'd get this. And so I think education really is the key.
Beyond the Greek yogurt.
Beyond the Greek yogurt.
But it's so much, isn't it, in terms of kind of gender equality or inequality? Because again, in that same podcast that we're going to shout some more, but around as soon as there's something that might be impacting men, it's like, right, all the studies, all the money, Viagra, and women classically kind of plough on, as you said, in terms of that inequality, in terms of stigma. And I was also thinking about life cycle transitions, because not always, but it might be typical that a woman might be going through menopause at the same time as having adolescent children. And actually, that was certainly true for my mum. And I think, when I chat to my mum about menopause, often it is like, oh, it was just, there was a lot going on in the house, which there was, but I'm sure some of it was also that menopause as well. Because I guess you've got that mixing with puberty and adolescence, and it's a perfect storm in a lot of households.
Absolutely.
Isn't it?
And this is, like I said, the sandwich generation, and then you've got, your relationships as well. If after menopause, suicide goes up, divorce rates go up, and for a multitude of reasons, people leaving the workforce. So we really have to support these women that, in the past have been forgotten. Once you're midlife, middle-aged, you just see, we've just got to reframe how we want to see middle age and how we want to see longevity, and how we, we're not going to turn into that little old lady with a stick. That's a typical how we think of an 80-year-old. And I think we're starting to reframe that. And again, middle age, just, flapping yourself, middle age paunch, not doing much about it. And now, we've got so many women are quite inspirational, showing us that it doesn't have to be that way. And we can all do it. It's, we've all got it within us to take control.
Love that. Such a beautiful way to end this conversation. Love that. Thank you so much, Elise. Fascinating conversation. I've learned so much. Honestly, I've learned so much. Thank you. So if people want to find you, are you on social media? Can people
Yes, I've got a
you?
very little Instagram channel where I try and do a lot of awareness when I have the time. But yes.
What's the handle?
Dr. Elise Dallas.
Dr. Elise Dallas.
There you go.
Also,
my full name.
Also, can we share the chat?
Oh, yes. And I write a column called Ask Dr. Dallas in Chat Magazine. But that's for everyone. So if you've got any problems at all, DM me through probably best my Instagram channel, because unfortunately there's no online version. And that's about anything.
Okay.
So I answer 4 questions a week with that.
Lovely.
Amazing.
Thank you so much. So we have been Free Social Workers chatting with Dr. Dallas about menopause. If you'd like to follow us, we are on Instagram at Matters Podcast. You can also follow us on LinkedIn, Social Matters. We really hope you've enjoyed this conversation. Do share this if you found it helpful and interesting. Do share it among your friends, family, because as we've kind of spoken about, it's not just a conversation for women. So yeah, take care of yourselves and we'll see you soon. Bye.
Bye.